Okay, let's make a start. Hello and welcome everyone to this edition of the MAHSC seminar series. My name is Neil Speak. I'm Professor of Health Informatics and I'm also Director of the Christabel Pankhurst Institute for Health Technology Research and Innovation, which is the topic of today's seminar. We're going to have two presentations, one by myself, and that's going to be followed by a presentation by Will Dixon, who's going to talk about the International Centre for Translational Digital Health, collaboration with the Universities of Toronto and Melbourne, and one of the major initiatives within the Pankhurst Institute. So let me start by sharing my screen. Here we go. I hope you can see that. So the Christabel Pankhurst Institute for Health Technology Research and Innovation is a new institute, and I'm going to tell you all about that in the next 20 minutes or so. It is named after Christabel Pankhurst, one of the suffragettes who fought for women's voting rights about a century ago. We see a picture here of Christabel on the left-hand side. On the right-hand side, we see a drawing of the Pankhurst building, the main Pankhurst building, which is going to be on Dover Street on the Oxford Road campus. And that building is actually nearly finished. It's going to be finished by September, if all goes well. So let me start with telling you about why we felt that it was important to have this institute, the Pankhurst Institute. And I'm going to start with a couple of news items that some of you may have seen from the last 12 months roughly. So in the top left, we see some news items about Google Health, who pulled the plug on their app Streams, which was developed with the Royal Free in London. So that was from August last year. And I think very soon thereafter, they also said, we're going to dismantle our entire health division and approach the topic of health completely differently from a strategic perspective. And this is actually the second time that Google tried to step into health and failed to do it. The first time was, I think now 15 or 16 years ago with the Health Vault. That also didn't work out. And I think it's reasonable to say that, again, this time, it wasn't very successful, which is quite remarkable for a company like Google. You would expect that if anyone's able to do it, it's them. But apparently they couldn't. Then in the bottom left corner, a paper from the Mid-Technology Review from about a year ago now, I think. Hundreds of AI tools have been built to catch COVID. None of them have actually helped in clinical practice. So quite a concerning story there. Then more recently in January, it was announced that IBM have sold IBM Watson Health after having it in the shop window for about 11 months. And I think it was already earlier quite clear that they would not be able to maintain IBM Watson Health because it wasn't a success. And then very recently, Sensign, an AI company, had to send away 2/3 of their workforce because of financial problems. So quite a few concerning issues there. And in one of the papers I read about this from Bloomberg, it was said there's a clash of cultures between the ambitious and iterative world of engineering, where problems can be solved with the right algorithm, and the world of medicine, which calls for a much more cautious approach. So medical researchers at health tech firms have complained of being steamrolled by the move fast and break things approach of highly paid software engineers. And the other side, the techies, complain of being unable to experiment freely in a world that seems to be obsessed, from their perspective at the very least, with patient safety and regulation. I thought there was a really interesting quote and sums it up really nicely, because I think this field of health technology and health innovation is really all about that. We have to bring these two worlds of technology and health together somehow, but it's extremely challenging because they are really, well, not just different worlds, different planets, I would say. And that emerges from, the language that people speak who come from these different planets, the things that drive them, both individually, but also as organizations, how they work, but also, for instance, how they get access to resources, particularly to money, but also the things that they are obsessed with, and the things that are taboos. And perhaps it's true, that in health, we tend to be obsessed a little bit with patient safety, but I think also that's understandable given the history of medicine. If you come from a technology world, from a technology perspective, sometimes it can be really, really hard to understand why that is. And your first reaction might be, that needs to change, that's unworkable. And I think that's understandable, but in the end, where we often end up is that the two worlds, the two planets can't work together. They don't make it. And I think for me personally, certainly, that's one of the reasons why we felt it was important to have this new institute, the Pankhurst Institute. So the vision for the institute is to have a multidisciplinary institute for health technology research and innovation that capitalizes on the academic excellences that we have at UOM in digital health, AI, and advanced materials, catalyze research and innovation to meet real healthcare needs, and accelerate translation into practice through whole life cycle support. It's a partnership with the local government, with healthcare organizations, with industry partners, and with Health Innovation Manchester. And there's a total investment of 25 million going into the institute over a total of 5 years. As I mentioned, we've got a building at Dover Street, which should be finished in September. So I hope once that is finished, you're very welcome to come and have a look. Then we're also going to have offices in City Labs 4. That is going to be on Heiferstage Road, so basically at the other side of MFT, if you come from the Oxford Road campus. It's the delivery of that building is a little bit delayed. It's going to be delivered now in 2024 is the expectation. So then we will have offices there as well. So much of what we do in the Pankhurst is about understanding translation. And we've got also someone who leads a translation theme, Dr. Claudia Lindner, who's a Wellcome Trust Sir Henry Dale Fellow. And I think one of the things that is already striking is that different fields have developed their own frameworks to understand translation and, for instance, express different levels of maturity. So this is one that originally comes from NASA and uses something called technology readiness levels. A number of you might be familiar with it, to describe those different levels of maturity. And this is all about technology. And as I said, originally originates from the space world, but is now used, for instance, also by EPSSC and other research councils, and generally, I would say, in the technology world. In the health world, we tend to look at these things slightly differently with different terms and different concepts. They do relate, I think, to the same things, but this is, I think, one conceptualization of the translational roadmap that is often used in medicine. So we tend to think of discovery research to gain knowledge, which then needs to be brought into patient-centered research, which is also often called translational research. And then finally, we can make changes to healthcare and to practice, medical practice, and to treatments. I think in order to achieve translation, it's good to think about these different stages of translation and about these different levels of maturity. But what you really need to make it happen is an ecosystem where people that are active at those different stages and different levels of maturity can work together and interact and understand what each other's needs are. I think we have achieved a lot of that already in Manchester, and a very good example actually is Advanced Materials in Medicine, which is part of the Pankhurst now. It existed already before there was a Pankhurst, but it's now incorporated into the Pankhurst. And I think this slide describes really well how Advanced Materials in Medicine works with other organizations and infrastructure like the Royce Institute, for instance, and also the Pankhurst, to create that environment, that ecosystem that can facilitate innovation. So going back to the Pankhurst Institute, we have three broad technology areas that we focus on. So I've mentioned materials already. Then there's digital, and there's AI. And we've got a number of cross-cutting initiatives. So the first is translation, which I've already mentioned, which is led by Claudia Lindner. Then there's also responsible and inclusive innovation that's led by Robert Mackin from School of Social Sciences. And then we have a number of themes, and that is also quite still emerging. So we have a couple already, and I'm sure that more will be defined in the months and years to come. So in terms of the initiatives that we currently have going, we've got a number. So I've mentioned advanced materials in medicine. We also have a digital health inequities seminar series, which some of you might be familiar with. One of our newer themes is multi-omic health technologies, led by Dr. Juhi Gupta. And then there's a number of other things which I'm going to talk about in a second. But let me first go to my next slide, which shows the leadership team. So Julie Guff leads the advanced materials theme in the Pankhurst. I've mentioned Claudia Lindner. Chris Taylor is the chair of our board. I've also mentioned Robert Mackin, who leads responsible and inclusive innovation. And finally, Sami Kaski is our research director. So going back to the slide that we saw, so Will is going to talk about the International Center for Translational Research in Digital Health in a second. I'm, in the remainder of my talk, I'm going to talk about two initiatives which are, I think, really important for the Pankhurst. So first is the ERDF RNI Health Accelerator, and second, the GMCR records. So the Research and Innovation Health Accelerator is a collaboration between Health Innovation Manchester, the University, the Innovation Factory, Manchester City Council, and BUNOW. It's funded through the ERDF, so the European Regional Development Fund. And basically what it does, it invites SMEs, so small to medium-sized enterprises, to collaborate with GM's RNI institutions to accelerate development and improve commercialization of innovative healthcare products and services. And SMEs can access expertise and support, including, for instance, navigation about how to navigate that complex health and care system and all the regulatory approvals, for instance, that you need in order to introduce new products and services into healthcare practice. They can also receive support in developing value propositions. So, for instance, the people from Health Innovation Manchester provide support in that, Bradley Quinn, but there's also a health economist, Alex Thompson from University, who helps with that. There's also access to wider university expertise through this project. The focus is on AI and digital technologies, medical devices, biosensors, genomics and precision medicine, diagnostics, biopharmaceuticals, and advanced materials. Right, so since the project started, which was in December 2020, on a monthly basis, applications from SME have arrived. Initially, there were a lot because obviously we told people that this was coming. We knew it was coming when we got the award. It took a while to get all the contracts in place so we could actually start. So I think very soon after we started, immediately 18 applications came in. So they had been waiting for a while. That number dropped off gradually after that. I think now we're typically at, 2 to 3 applications per month. And just a couple of examples of the companies that have engaged with the RNI Health Accelerator. So for each of those, we've indicated also what the TRL level is, and you can see that varies a lot. So we've got companies like Graphene Trace, who are TRL level 3, which means that they've got quite a long way to go before they will have actually services routinely deployed in the NHS. There's also others, so Chromition, for instance, and diagnostics, who are at slightly more mature levels, so 4 and 5. But then we also have companies like Koku, which is actually a spin-out from the university. That's about gamified falls prevention. That is at TRL level 8. So basically, there we have nearly all the evidence that we need to roll it out in routine clinical practice, but we just need to make that final step. And Dignio is another example. That's at level 9 already. That's about remote patient monitoring and virtual wards. And actually, that is used already in health and social care across Manchester. So let's move on to the Greater Manchester Care Record, and this is going to be my last few slides of my presentation. So most of you will probably have heard of the GM Care Record. It was stood up in a partnership between the university, the Greater Manchester Health and Social Care Partnership, Health Innovation Manchester, and technology provider GraphNet. During the pandemic, so early on in the pandemic, and that we're speaking now, April, May 2020, the GM Care Record became available for direct care purposes, specifically to support the NHS in the fight against COVID. But essentially, it provided full healthcare records for all the citizens in Greater Manchester, so 3 million people, for all healthcare providers. So quite a step change. And I've actually spoken to many clinicians who use the record on a daily basis in their consultations, and they've said to me, this is fantastic, because there's now all the information that you would normally have to get from the patient yourself readily available through the record. So really an important innovation in the region. The GM Care Record is not just available for direct care purposes, but also for secondary uses. So that includes, for instance, planning of resources, but also research. And that's where we come in, where the Pankhurst plays an important role, because we help university researchers with getting access to the GM Care Record for research. So in order to make this happen, a replica of the record database has been migrated to a secure public cloud platform, the GraphNet Care-centric BI, for secondary users, including research. Previously, that was only for COVID-19 research, or I should say until now. In the future, we expect that it will be available for all types of research, so not just COVID-19 research. Within the platform, we can set up virtual machines to give researchers access, not to the entire GMCR database. We haven't got a license to do that, but we can create bespoke subsets that are tailored to the specific research question that researcher or group of researchers is trying to answer. So that bespoke subset, that tailored data set is created by a team of research data engineers that work under my supervision. Before that happens, a proposal has to be submitted, which is reviewed by a group called the Secondary Users and Research Group. And they typically look at, is the data asked proportional to the question that is being asked? Is it reasonable that we can actually answer this question using the data? Are we comfortable that the data quality is going to be good enough? And does the analysis plan look solid? And are we confident that that will actually produce the results that we're looking for? The data will never leave this cloud platform. So all the analyses are conducted within the virtual machines, and only the results can then be taken out. So what is it that we can do with this resource, with this care record? So there's obviously epidemiological studies and public health studies that we can do with the record, and there's quite a few actually that have already been conducted or are still in progress at the moment. So for instance, Lamise Hassan and Joe Firth are doing a study looking at COVID-19 mortality in people with severe mental illness. That's nearly finished now. I think the revision to the manuscript was submitted, or is about to be submitted to the journal. So that's going to be out fairly soon, I would expect. And like I said, there's been quite a few other studies as well that have either already been published or are in progress. We can do more than just that. So we can also link to data, for instance, from hospital EHRs. So we've done that with cancer data coming from the Christie. So that gives us linkage between the primary care data and deep phenotypes that we typically have in hospital data. So that particular project looked at cancer and COVID-19, and particularly the role of comorbidities in the risks surrounding COVID-19 in cancer patients. We can also use the record to evaluate interventions. And a really nice example of this is currently being led by Martin Rutter, who leads an evaluation of My Diabetes My Way, an app that was used during the pandemic for self-management in diabetes patients. Then we can also set up prospective cohorts, so start new data collections, which are then prospectively linked to the Greater Manchester Care Record. A really nice example of that is a study led by John McDermott in pharmacogenetics. And finally, there's also the opportunity to innovate, to do new things that previously weren't possible with these types of data. And we're working very closely actually with GraphNet, the technology provider, to do that. So they have a data science team that have capabilities in text mining. And we use that now, for instance, to incorporate microbiology reports, which typically are provided in text format, which means they're not available for research. But we can use text mining to make those reports still available to researchers. And I think soon the first study led by Chris van der Gast and Noir Bakerley will be starting using those microbiology reports. So just to summarize, the Pankhurst is a new cross-faculty institute for health technology research and innovation. It's a partnership with local government, health and care organizations, industry partners, and Health Innovation Manchester. Our key objective is to bridge that gap between health and technology. And it's always going to be very challenging. We know that, but I think we can do that by creating that ecosystem that you need to do that. So our key objective is to improve and accelerate health innovation through that multidisciplinary collaboration between all the stakeholders in the innovation ecosystem. And our main technology areas are digital health, AI, and advanced materials. So thanks very much for listening. Feel free to visit our website and read more about the Pankhurst. Feel free also to get in touch, either via the generic Pankhurst email address or directly to me. And thanks for listening. So Will, with that, I'm going to hand over to you.
Thank you. So thank you, Niels. I think I need to change that to there. No, that was wrong. You see the full screen now?
Yeah,
we do.
Okay, great, thanks. So I'm going to talk about what was the Joint Translational Centre for Digital Health between Toronto and Manchester, but which has evolved in recent times, more of that through the talk. So the Joint Translational Centre began as a partnership between the Universities of Manchester and Toronto. It was founded following the establishment of a strategic partnership between the two universities. Somebody spotted that both universities have a tower. Now, many universities have a tower, but not many universities have a tower where, of the two turrets, the turret on the left is slightly shorter than the turret on the right. And so there was an important partnership struck up, and digital health was recognized as one of the important areas that both universities had strength. The mission of this Joint Translational Centre is to advance the field of digital health in Canada and the UK through research and training, those two really important areas, in order to realise the development, implementation and translation of inclusive and equitable technologies, policies and service delivery models. The purpose of the centre really is to establish a community of researchers trainees and partners across these two universities that accelerate the delivery of digital health in Canada and the UK, but as an example in these two countries to learn things that is relevant for the rest of the world too, providing that digital health leadership. The impact of the centre, we hope, will be to create and utilise new technologies, translate theory into effective and equitable public policy, train the leaders in the field of digital health, and strengthen health services delivery. But why these two universities? Actually, when you put them alongside one another, there are lots of similarities of strengths. So if we look at the population, the healthcare system and the healthcare governance, we both have similar urban regions with highly diverse populations and significant health inequalities as well across our populations. In Canada, they have the Ontario Health Insurance Plan, whereas in the UK, we have access to the National Health Service, as we all know. And there are similar governance between the governance of Ontario and then the smaller, but similarly structured Greater Manchester Combined Authority, where we look after the healthcare in our region. Now, Niels has already talked about some of this as the strength of Manchester, but interestingly, these are mirrored in strengths in Toronto. So whilst we have the Greater Manchester Care Record that you've heard about, there is a perhaps more mature but similar system in Toronto called the Institute for Clinical Evaluation Sciences, or ICES. Data science and AI are strengths in both locations. We're a health hub for the Alan Turing Institute, and there's a similar AI centre in Toronto called the Vector Institute that does work in healthcare too. We both have academic health science centres and networks, and there is also importance in healthcare innovation. Health Innovation Manchester, the Manchester Science Partnerships, plus everything else that you've heard about from Niels already. The Toronto base is co-located with the Discovery District, and they have digital health evaluation centres also. So some really important common strengths. As we established the centre around 12 months ago, we set up 3 themes or 3 hubs. The first of these is in remote monitoring and virtual care, with a number of specific objectives. So in remote monitoring, we're interested in deriving patterns of health and disease from smartphones and wearables, and again, shared strengths in the 2 locations. To integrate these insights into clinical and self-management decisions to improve services, patients' experience and outcomes, and to develop and scale up these models for virtual care delivery. Now, work was already going on pre-pandemic in this area in both locations, but obviously the importance of this theme is even greater as we've had to pivot to more virtual care, with having been removed the opportunity to see patients over the last 2 years. And it's a model that won't shift right back to normal. The second theme is in data science and AI, with the objectives to expand the scope of methods and models, to enhance the quality of translational science, so not just doing the analysis, but also making the models that come out of that be used in clinical care. And then thirdly, to facilitate access to data science and AI resources. The third hub, which is very relevant to the implementation of the other 2 hubs, is around health policy and implementation. So understanding the regulatory landscape and policy drivers for digital health technologies and practices in these 2 countries. And whilst I've shown you that there are lots of similarities, there are also lots of relevant differences that you really have to understand the details of if you want to implement something that has been developed in one country and apply it in a second country. The second objective here is to support social research focused on understanding the challenging nature of healthcare and promoting responsible innovation in digital health. So lots of laudable aims and objectives. How are we going to do it? Well, we want to establish this joint community of digital health researchers. So we started knowing that we had strong digital health research in Manchester and strong digital health research in Toronto, but could we make the strength even stronger by connecting those two groups, and we believe that we can. Having joined those people together, we want to establish areas of joint research that is of high quality and higher than we would have been able to do on our own. By joining these people together and developing plans, we then need to develop sustained funding through research grants and perhaps through industrial collaborations too. We want to make use of the partnership that we both have with our healthcare organisations and further strengthen this network of healthcare institutions as partners and living labs for the research. So the AI needs to happen on data, but how do we make sure that we get access to all of the right data and manage it in the most appropriate way? It's research, but also training, and therefore we need to develop training opportunities by leveraging existing things and share them more widely, or by creating new programs such as seminars, formal courses, travel bursaries, etc. We're interested in developing industry partnerships, though the framework for that is sort of still in development, and really interested in taking things that work in one country and applying them to the other. So this is really just a visual representation of what I've said, that there are these two areas of strength of research and training that together will lead to digital health development, implementation and translation. But I wanted to spend a few moments just giving you a real flavour of the details of what we've done so far in the first year. So highlighting joint research workshops and symposia and matchmaking. So each of the three hubs have held workshops bringing together experts from both locations. These were run through December and January. You can see here a picture of the virtual care workshop in progress, a hybrid meeting, some in person in Manchester and some virtual connecting with researchers in Toronto and further afield. That workshop is leading to a publication about the topic that I've just outlined, the complexity of transferring technology from one country to another. We certainly learned some similarities, but also of many different differences that are important during that workshop. That workshop brought together groups of people who, some of whom had met, but some of whom hadn't met. We then opened a funding opportunity which required there to be an applicant from both Manchester and Toronto. So this first round of seed funding was launched in February of this year. There were small grants up to £15,000, but there had to be a co-I from both places. There were short projects where the money needed to be spent by the end of the year. And we ended up awarding 4 projects here. And you can see the collection of the 4 pairs on the left. Now, some of these people were not, well, I think three of the 4 applicants were not already known to one another at the start and have been brought together through the centre and are now collaboratively leading work. The first in a comparison of policy and practice about access to online patient health records. The second, which is taking an established Canadian digital therapeutic in heart failure and thinking about how that can be brought over to the UK. The third is taking a digital health equity assessment tool that's been developed in Canada and applying it to a digital pay mannequin that has been developed and validated in the UK, but hasn't yet had its digital health equity impact assessed. And the fourth is taking a tool that's developed in Canada for de-identification and refining that over in the UK. But really illustrating that we are indeed, as planned, bringing together researchers from the 2 countries and doing research that we couldn't do in isolation in either of the 2 locations. To show some of the teaching activities, we said that we'd have joint teaching activities building on what already existed and thinking about joint programs. So here's the Manchester Digital Epidemiology Summer School that we've run in Manchester for a few years now. But as we developed the centre, we brought in colleagues from Toronto to contribute to this. And so the keynote lecture on the first day was from Mohammed Mamdani, who's a professor of data science in Toronto, And then one of the co-leads from Toronto gave the keynote talk in day 2 about remote monitoring. There are already existing joint PhD programs between the University of Manchester and the University of Toronto. Actually showing you one from the University of Melbourne here. But we're looking to work out whether we can ring fence support for joint PhD studentships in this area of digital health. And coming soon, we're planning now a celebration event to see what has been achieved over the course of the year, presenting the outputs from these 4 seed funding projects, and also to celebrate the expansion of the centre. So I told you that we're interested, the partnership began really because of the 2 towers. And it turns out that there is a 3rd university that also has an asymmetrical tower and turret, the University of Melbourne. And so the University of Melbourne has now joined what was the Joint Translational Centre and becoming the International Centre for Translational Research in Digital Health, founded this year. And the mission really has stayed exactly the same, except that we now have Australia as part of the partnership. Try to think of a better acronym than the ICTRDH. Does international really represent the 3 universities? So we thought about different acronyms involving the 3 locations. I had a Google for this. So Man-Meltor, we wondered whether we might call the Man-Meltor Centre, but it turns out that Man-Meltor is already a thing. It's a secondary weapon for the Pyro in Team Fortress 2, if anyone knows what that is. I certainly don't, but it's ideal for atomizing moon soldiers and neighborhood dogs at your earliest convenience. So it's been a real pleasure being involved in this. I co-lead it with Niels in Manchester. As we've brought Melbourne on board, Niels has managed to stay happy despite the hour difference. Here you can see working hours for the 3 centres in green, and you might spot that there's actually no overlap in working hours between the 3 centres. And one of the most convenient times for all 3 sites is 10 p.m. for us in the UK. So let me finish there, but to really celebrate the achievements of the centre in the last year. And we look forward to the future of advancing the field of digital health in Canada, Australia, and the UK through excellence in research and teaching. Thanks very much.
Right, thanks, Will. That was great and hilarious, I thought. So let's open up for questions. Any questions or comments for either myself or Will? Ruth.
Thanks, Will. Really interesting. I was just going to ask you, has anyone done some forward planning and actually reviewed how many universities have a turret with the smaller on the left and larger on the right, so you actually know what you're building towards there? Because it could be really small or really massive.
Good question, Ruth. No, but I think you might have just picked yourself up a job.
Jonathan.
Thanks, Niels and Will. That was really interesting to see. Firstly, I think, Will, on the, I suppose, those kind of international collaborations, that as the Academic Health Science Centre, we are members of the Association for Academic Health Centres International, and we've been working a lot with kind of North American colleagues, specifically around workforce. So it'd be interesting to pick up those conversations. I think some of the issues we found in that actually are that there are, clear differences between UK and US systems, and things aren't always comparable. So I think it's quite good to see with the Canadian system, things may be a bit more comparable. And then I suppose, Niels, a question to you that, and you may have already answered this in your talk, but I suppose with the Gold Acre review around, use of data in NHS and the development of trusted research environments, I suppose is this kind of debate at the moment between, having a kind of nationalized data structure with, with rules and regulations around it versus having the, I suppose, the flexibility to do things more locally and on that deep phenotype level, as I think you've probably mentioned with the work you did with Corinne around cancer and COVID-19. I suppose, is the GMK record, I adaptable to both of those things at the moment? Are we able to, respond to the recommendations from that goal-local review, but equally able to respond to those like local needs and the deep phenotyping?
Yeah, so thanks for that, Jonathan. So yeah, we've obviously looked at the goal-local review quite thoroughly, and we're quite happy to see that as it stands, we already adhere to most of those recommendations in the report, and I think it will be easy enough to make a couple of small changes so that we also adhere to the ones that we currently don't adhere to. I do agree that I think it makes sense to organize things at a national level, because there you can achieve scale that you would never be able to achieve at a regional level. So with national databases, for instance, it's possible to do research into rare diseases, rare side effects, rare outcomes that we would never be able to do with the 3 million database in Greater Manchester. So you need that clearly, but with regional initiatives like GMCR Record, you can really innovate. So you can indeed, for instance, link to deep phenotypes from other databases. You can experiment with innovation like we do with the colleagues from GraphNet using text mining. So I think that there's a lot to be gained from those regional initiatives. So I think you really need to have both. I think potentially you could also consider a federated infrastructure where you have regional databases which can be queried nationally without bringing them physically together. That is probably not going to be the direction of travel in the UK, but it's interesting that there's actually quite a few other countries, I would say most other countries, that take that approach, that are not very comfortable with creating country-wide databases, but instead take the federated approach. I think both are viable, and as long as you can guarantee good security of all those databases, then I think either approach is good and will work. Jane.
Thanks so much, both. Just a quick one on how the pandemic and COVID might have changed the way you work. Has it increased collaboration, partnerships internationally? Yeah, kind of what effects has it taken, positive, negative? I'm just interested to hear from both of you. Thank you.
Well, I think I mentioned one of the themes had really been, its importance had gone right up the agenda because of the pandemic, virtual care and remote monitoring. I mean, we've been doing it in Manchester since around 2015, and you have to make quite a strong case at that time that this was important. And then suddenly, having done the work and having understood how it could be implemented in the NHS, everyone wanted to know how it could be achieved. I mean, I think international collaboration, remote collaboration has obviously become the normal way of working for all of us. You know, here we are on a Zoom call that probably wouldn't have happened pre-pandemic. And international collaboration becomes much easier because of that, we're all used to working in this way. So establishing the centre at this time has been probably easier than it would have been at other times. It doesn't quite get around the time zone issue, but we're working on that.
Yeah, exactly. I think that is really important. If we had tried to do this before the pandemic, I think everyone, including ourselves, would probably have questioned the viability of the whole idea, because everyone would have said, "Oh my God, that's just travel." And yeah, during the pandemic or since the pandemic, that whole concern has evaporated. We will still travel every once in a while to Toronto and Melbourne with small groups. I think it's important to meet people also in person, but there's no question that you can make it work virtually via Zoom and other digital means. I don't think there's anyone who has concerns about that.
There's a question in the chat from Louise Carter saying, given the failure of the AI medical collaborations discussed at the start, how are you doing things differently to avoid those pitfalls? So relevant to what you were saying, Niels, about Google Health failing and the other failures. Do you want to answer that? I mean, I've got thoughts too.
Yeah, thanks, Will. It's a really good question, Louise. And I think what we're trying to do, I think, Andy Burnham once said, and I thought it was put really, really well, that Greater Manchester is big enough to really achieve something, but it's small enough to know each other, to know people, to know each other. And I think also you could add to that to trust each other, to build up relationships and trust each other. I think developing the ecosystem where you can innovate is absolutely crucial, and trust will always have to be the basis for that. Personally, I've extremely enjoyed, for instance, working with colleagues from Health Innovation Manchester and from GraphNet during the pandemic on the Greater Manchester Care Record, which was a major innovation. And it was very important that, all the parties that were involved trusted each other, that we were doing the right thing and that we would all do it right. And I think in a lot of the investment that went into AI in the last 10 years, the expectations and the approach were slightly different. They were focused on achieving very much, very, very quickly. And that led actually to the opposite, where people didn't trust what was going on and felt, they were being steamrolled by the other party. So I think there's an opportunity to do things differently, certainly here in Greater Manchester. You have to take things, at a slightly different pace, I think, than sometimes has happened in the initiatives that I mentioned. But I do think it's possible if you focus on the people and the relationships. Will?
Yeah, no, I think trust is really important, isn't it? And the area of healthcare is particularly difficult because health data are sensitive, and all of our learning about health comes from analysis of health data. But this is things that are personal to individuals and some of their most sensitive information. So the idea that you can kind of come in and transform healthcare because you're a tech giant without building those relationships carefully, it's really needed. And the healthcare system is painfully complex, and so it does take time to sort of understand how it works. So it takes time to build up partnerships of trust and understanding. And I think that's what we have within academic health science centres. We have a shared understanding of how the healthcare system works, how that can partner with academia, and it's a really good foundation to do this innovation. I mean, I think we can do industry partnership with that and help them understand quicker than they might otherwise. But it's quite a difficult problem to solve. But maybe they've, like they like to do, fail fast.
So I see there's another question in the chat from Lloyd. If someone has some research that would benefit from GMCR, what is the process and timescales for accessing it? So how it works is as follows. Basically, you would start with submitting a very lightweight application that is a brief outline of what you're trying to achieve, of your research question and what it's about. That is then picked up by my team, the Greater Manchester Care Record operations team, to be worked up to a full application together with the researcher that has submitted the application, if indeed it is within scope, because we need to check that first. So we will then work with the researcher to basically develop a full protocol, and that includes the research data engineers looking in the database whether the research is actually achievable with the data that we have. So that involves, for instance, querying for specific phenotypes and see whether they actually exist and how often they exist in the data. And sometimes at that stage, we have to conclude, well, this is a great idea, but we can't really do it with the Greater Manchester Care Record. If we feel we can do it and the proposal is finished, that's taken to an oversight group, the secondary users research group. They meet once a month, and normally, because the preparation of the proposal is quite thorough with my team, they would approve it, and we know, what could be contentious issues, and so basically how to prepare a proposal such that it stands a good chance of being approved in that meeting. And then GraphNet and the team of research data engineers is going to give the researcher access to their bespoke cohort. Overall, that process can take, I would say, between 2 and 4 months. Sometimes we can do it quicker, sometimes a little bit slower. Certainly if there are concerns, for instance, from the oversight group, and we have to go back and revise the proposal, that takes time. So those are roughly the timescales. I should add to that, but by the end of June, our current legal basis for accessing the data, the copy notes, will expire. So there's a change in the law, essentially. So there's going to be a slight delay over the summer in accessing the Greater Manchester Care Record. We've got a number of proposals that will be approved before that happens, and we expect that they will get access as normal and can do the research over the summer. But new ones will probably have to wait a little bit before we make the necessary changes to deal with this change in the law. I hope, Lloyd, that answers your question. All right. Any other questions or comments?
I think we've come to a natural close. So yeah, just to say thanks so much, Niels and Will. That was great today. Any other questions, feel free to contact myself, Niels or Will directly, and we look forward to seeing you at next month's seminar. Thanks, everyone.